opportunity to speak to you today. Appreciate the invitation from Professor Morgan. I'm going to talk a little bit about pediatric chronic rhinosinusitis when we operate, and also get a little bit as well as the rhinosinusitis as well. I've done some disclose. We're going to really just talk about some of the definitions of pediatric rhinosinusitis, at least they're understood or accepted in the U.S. And then discuss some of the approaches for children with sinusitis, and also focus particularly on pediatric chronic rhinosinusitis. So I put sinusitis in quotes because it's a very common issue and very difficult sometimes to diagnose properly because of the fact that most kids, at least in the United States, get about 6 to 8 upper respiratory infections that are viral origin every year. And then these symptoms are cough, nasal obstruction, purulent, runny nose, fevers, post-nasal drip, are basically the same symptoms that you would have for sinusitis. And a lot of kids in the U.S. are in daycare and have a lot of infectious contacts, so it just makes it even more difficult to appropriately diagnose. In the U.S. right now, sinusitis it costs about over $5 billion in healthcare dollars to manage. The actual incidence of pediatric rhinosinusitis is very difficult to estimate. In the U.S., we say it's about 5 to 10% of children with upper respiratory infections will develop into acute rhinosinusitis, and then a subset of those will then progress on to chronic rhinosinusitis. So we need to differentiate acute rhinosinusitis from chronic. It's like apples and oranges, two different things. We use the adult temporal definitions to sort of say what's chronic and what's acute. So chronic is going to be greater than 90 days of continuous symptomology. Etiologies of pediatric chronic rhinosinusitis are multifactorial, and we probably don't know all the reasons why it occurs. Basically, there's some form of inflammation, and there's also symptoms as a result of that inflammation. And bacteria really is shown it's not really necessarily the primary issue here. So as I said, very multifactorial. A lot of different reasons why we get chronic rhinosinusitis. But as I said, the definition is at least 90 continuous days of 2 or more symptoms of purulent rhinorrhea, nasal obstruction, facial pressure pain, or cough, and either or endoscopic signs or nasal signs of mucosal edema, purulent drainage, nasal polyps, or CT scan evidence of mucosal changes, especially in that osteoid complex or any of the sinus epithelium. So we also want to separate out those patients that have polyps and those that don't. So we really need to categorize what is going on as far as underlying disease, and then especially delineate those patients that have some of these other issues such as immunocompromised state, cystic fibrosis, PCD, and otherwise. The diagnosis is definitely clinical. It's difficult to distinguish from other common symptoms, especially cold, allergic rhinitis, and so forth. As I said before, very non-specific symptoms. History and examination are very important for diagnosis. Having, as I said, at least 2 of these symptoms and along with the intranasal exam or CT scan. We can do an anterior rhinoscopy with just an otoscope. Kids know what it is, so they're usually not afraid of it. Use a headlight with the nasal speculum. They're a little more afraid of that little nasal speculum. We're not sure what that is when they come out of it. You're taking care of kids. The flexible nasal laryngoscope is very useful for looking in the nose of kids. I do it very frequently, very easy. I kind of show especially young boys, they have them put it next to their finger, and they say, well, which finger do you pick your nose with? Maybe you say this one, and then well, it's smaller than your finger, so it'll fit just fine. I don't usually use a rigid endoscope in kids in the office because if they move around too much, it gets too dangerous for the nose. You really want to examine the nose, the lining, the middle meatus, looking for masses, polyps, and especially foreign bodies, especially if you have a unilateral purulent rhinorrhea that's persistent. You want to make sure there's no foreign body in the nose. We want to suspect immunodeficiency if you have a child that's requiring antibiotics for treatment of upper respiratory infections more than 4 times a year. They need IV antibiotics to cure any of these infections. There's evidence of big infections, deep infections, evidence of invasive forms of infection, not necessarily only sinusitis. They cover UTIs or urinary tract infections, especially male, pneumonia twice, or multiple ear infections over the age of 4. These are all things that make us think that maybe there's something else going on. In general, just some of the things we can look at in the nose in a kid, just normal anatomy. The middle native is sitting up in the recess, and then you have cases where you have this mucopurulence sitting up in the middle native, or back in the recess. And this we would target culture, that would be target culture for. This is just pictures of an adenoid in the back of the nose, just things that we would see. This we've got a little mucopurulence on it here. We don't find lateral neck x-rays or any imaging of the sinuses are not recommended as far as the clean films are concerned. We don't really get CT scans of them unless we're thinking that we're going to head toward surgery or we're at the completion of management and the individual is still symptomatic. We rarely get MRIs unless we get thoughts like a basic sinusitis or something. There are evidences and studies that have shown that there's concerns about radiation exposure, especially kids and very young kids, and there's thoughts about potential risk for leukemia and brain tumors. Also, secondary, about 2% of malignancies in the U.S. are thought to be potentially as a result of getting CT scans of young kids. The management of pediatric chronic sinusitis is typically very aggressive antibiotic therapy up front. And that, the clinical consensus paper out of the American Academy of Allergology, they basically said that it's about 20 days of continuous antibiotics. And then they also noted that adenoidectomy in those people that failed that typically results in about 60% resolution of symptoms. Adenoid size itself does not correlate to symptoms. So they can have small adenoids, but still have a lot of problems with the nose. So the first line of surgical treatment for refractory chronic rhinosinusitis would be adenoidectomy. So this is, as I said, there was a clinical consensus paper that came out in 2014 from the American Academy of Allergology. There's similar statements that came out from the European Rhinological Society as well. And they basically go, there's 20 days of antibiotics, culture-driven, topical nasal steroid salt, and then the last was a pure treatment of reflux disease. Does not have really shown that there's any particular benefit of doing that. Inhaled nasal steroids, these are something called for vestibules. They may be considered as adjunctive treatment. Something to consider. Red flags, that things that you want to really be concerned about when you see these in a child. Nasal polyps. I'll talk a little bit more about that as well. I said unilateral findings, that's when you're going to want to worry about a foreign body. If you have any orbital findings, then you're going to worry about if there's something going on as far as the exacerbation or complication of sinusitis. So nasal polyps, all kids that have nasal polyps should be evaluated for cystic fibrosis. It's often, if you see these polyps, it's going to be evidence of something else going on. Because it's not very common to see polyps in kids. You can see it with liver fungal sinusitis and other disorders, but usually these kids require more aggressive therapy. Cystic fibrosis in the U.S. is about 1 in 3,000 births. It's autosomal recessive. There's a gene that's noted for it, and then particularly there have a lot of sinusitis and coronary disease issues. Fortunately, with the enzyme replacements and therapies that they have currently going on, a lot of these kids don't do as bad as they have even 10, 20 years ago. In these kids, you have a lot of problems with sinusitis, they have a lot of nasal polyps usually, and the offending bacteria is very often either Staph aureus or Pseudomonas. Gold standard for testing is a sweat test, and we're looking for an elevated sodium levels. And we would consider surgery in these individuals when their symptoms are getting really severe, just chronic obstruction that causing really quality of life issues, or if their sinus symptoms are actually exacerbating their pulmonary issues, and then we would consider surgery. Otherwise, we're just taking these kids to anesthesia, putting them under for a few hours, and actually put their lungs at risk. PCD is another autosomal recessive disorder that we have to think about in kids. It's about 1 in 10,000 to 1 in 20,000. Early diagnosis of this is very important. You have to have an early, sort of an index of suspicion for these kids. It's sometimes difficult to diagnose. A lot of these kids were presented as neonate with having just chronic respiratory issues. Almost all of them have this chronic, daily, persistent wet cough that goes all year round. If you see someone like that, then you want to be concerned about potentially who they have PCD. About 50 to 60% of kids with PCD do have situs anomalies, either situs ambiguous or situs ambiguous. And then for diagnosis, it's a combination of kind of two things, either daily, year-round wet cough, being in the first year of life, daily, year-round nasal congestion, or unexplained respiratory illnesses or distress, and then you see an x-ray that laterality of organs is off, and you want to really rule out PCD. Genetic testing, only about 65% of genetic anomalies responsible for PCD are known. And there's other tests that we can do. But even ciliary ultrasound structure is only abnormal in about 70% of individuals. Fungal rhinosinusitis, two different types we worry about. The non-invasive, invasive, obviously invasive is life-threatening. We can worry about that, especially in acute situations when you're in a compromised post. The allergic fungal sinusitis we do see more in the southern parts of the U.S., more areas where there are more humid noise. It's an IgE, mediated hypersensitivity, and then you typically on CT scan, you get this sort of expansion of the sinus area because of just the chronicity of the secretions of the swelling that occurs in the area. Typically treat with the steroids, surgery to open up the sinus and drain them, allow them to get the secretions out, allow them to ventilate, and then also allow you to irrigate the sinuses. This is a picture of those acute invasive fungal rhinosinusitis. This is an individual that have immunosuppression for longer than 2 weeks. They ANC less than 600. We're going to be really concerned about if you finding a black eschar in the nose or the nose is very pale. It's insensate. It doesn't bleed. CT scans are important to get. Sometimes you don't really see much on them, but it makes it a little bony. Hyperdensity in the bone, you may want to be concerned that there's something going on as far as the process. You really need the surgery to read these early, quickly, and get as much of this disease out, try to get back to bleeding bone, so evidence that it's actually the live tissue. Unilateral findings, I said before, foreign body. One side, purely brain and trying to read, you really want to rule that out. And also the other thing that sometimes you can have is unilateral corneal atresia. These individuals will sometimes miss until they're a little older because they're able to breathe well and it's a neonate, so they miss anything checked that they've seen. Once in a while, we'll see some lesions in the nose like a JNA or an ossified fibroma that's causing obstruction, and very rarely, unfortunately rarely, malignant lesions. So the role of surgery in pediatric chronic rhinosinusitis is typically if you fail medical management, and that's kind of nebulous on exactly what maximal medical management is. It's hard because there's people there to emphasize what it is. But typically it's that 20 days of antibiotics at minimum. And then you want to start with the first line of medical surgical management would be an adenoidectomy, even if the adenoids aren't large. There's about a 60% rate of success for adenoidectomy alone. And then there's the thought that because even with small adenoids may be able to cause biofilms. So the clinical consensus statement that did show that adenoidectomy had a beneficial effect in patients with pediatric chronic rhinosinusitis, independent of endoscopic sinus surgery. Therefore, that's why we recommend doing that first before you go on to doing endoscopic sinus surgery. The adenoids are shown to potentially as it serve as a reservoir for bacteria. That's what they recommend doing. There's been papers that show that the biofilms within the adenoids also leading to blood that should be removed in case of refractory symptoms. Endoscopic sinus surgery is sometimes a little bit difficult to do in children, so you sometimes will do like a mini test. Just take the onset process down, make sure that the osteotomy complex is open, they take the bowl down, not do too much in the way of invasive or excessive dissection. And then if they continue to have symptoms or the CT scan showing evidence of disease elsewhere, they may be a little more aggressive. But there really isn't any good randomized controlled studies yet looking at the long-term benefits of PES. We do anecdotally know that this can help. And once again, endoscopic sinus surgery best treated after failure of medical and adenopathy. As I said before, we usually do like a widening of the nasalotomy. We don't always take down the lateral nasal wall as the ostomy complex. Sometimes we'll just take off the process and just make sure that the ostomy is open and clear. Care must be taken when you're taking that onto the complex down, that you don't traumatize that lateral nasal wall, the lateral aspect of the meningitis. Otherwise, you can end up causing scarring of the ostomy going to the maxillary sinus and then the surface. If there's purulent drainage, we can want to culture that and then drain it into say the material. So mainly what we're trying to do is create a space that we can be able to irrigate out using saline and just natural measures. Really rinses, medication in the nose, really trying to let that get into those spaces. So as I said before, a lot of these patients do benefit. They do require sinus surgery. From the surgery, improving symptoms, improving quality of life. Poor predictors for outcomes are those individuals with history of asthma, allergies. They have had polyps in their nose, and they have current polyps. They usually aren't improving as well. Really young kids that undergo sinus surgery are probably not going to do well. Those people with nasal polyps, as I said before, you got to rule out evidence of potential for cystic fibrosis and liver fungal sinusitis. Really, if you're going to do surgery, you got to clean them out aggressively, remove polyps from the antrum, evacuate any exudates, and use them as present. Really make the ostomy wide so that you can irrigate out these sinuses. There's a lot of papers out there that are looking at potential for using balloon sinuplasty. There's limited information whether or not it really is truly helpful or it's better than doing endoscopic sinus surgery, but no long-term data yet, so we're still there's no consensus statement that they couldn't make a judgment on that because of the fact that there wasn't enough data. Other surgeries that we may consider for people that have symptomology of nasal obstruction or purulent drainage, it says rule out coinotresia. Have that, then rule out coinotresia will need to be prepared. Sometimes if there's a large concha bullosa, that may actually cause obstruction of the ostomy complex. You're going to take that down. Other things, paradoxal middle turbinate may require resection of the middle turbinate. And if you have severe septal deviation right in the area of the mid-part of the turbinate, you need to straighten the septum as well. These are all things that we're going to want to make sure you address if they're present. Headaches really are a non-specific symptom. We typically find that if we have a child that comes in and the primary complaint is headache, we do refer them to neurology, as most of them are going to be migraine related and not necessarily sinogenic. Overall, the pediatric chronic rhinosinusitis is unfortunately it's common and it does have a lot of impact on the quality of life and economical aspects. Imaging really isn't helpful with acute symptoms, and really we get CT scans for only those individuals that are going to go through surgery or are failing medical management or having recurrent disease. For the most part, if we do surgery, we're trying to, especially on the sinuses, with endoscopic sinus surgery, we're trying to open up the ostomy so that we can allow them to get either saline to breathe or topical medications so that they can start over the inhaled steroids. So really, you want to be really vigilant in these individuals, looking for underlying immunodeficiencies, other disorders like CF, BCD, especially in those cases that are really refractory and not really responding well to regular therapy. We need to keep those in the back of our mind when we're treating individuals with chronic sinus complaints, as they do present very similar to the uncompensated. Thank you.